Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment, Shout Texas Echo. Please note that we are recording these sessions for later distribution. Please note that anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat function. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. To all the Be Well Texas providers, please make sure that you identify yourselves during this session, or if you're joining via phone, please email your phone number and name to bewelltx@utisca.edu. Some housekeeping, please stay muted unless you're speaking. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, please press *6. We also encourage you to unmute and speak, especially during the discussion portion of the session. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. Or if you'd so prefer, you can use the chat feature to share comments and questions. Please note that no predictive health information is allowed in either the chat or our discussions. If you'd like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. Towards the end of the session, the Shout Texas Echo team will send out a link to an evaluation survey. All participants filling out the survey will be entered into a raffle for a $30 Walmart gift card. Our didactic today is on management of multiple substance use disorder in hospital patients and will be presented by Dr. Blair Walker. Following that, we will discuss a case presented by Dr. Janani Ramesh. We will start with introductions, followed by didactics, Be Well program announcements, case presentation, and open discussion. Thank you all again for joining today's Echo. In the spirit of all teach, all learn, we encourage you all to share your experiences, questions, and insight in today's conversation. With that, we will do some introductions. Dr. Walker.
Hello, everybody. I'm Blair Walker. I'm with psychiatry here at Dell Medical School in Austin, Texas.
Thank you so much for joining us today, Dr. Ramesh.
Hi, everyone. I'm Jan Ramesh. I'm one of the hospitalists at Dell Medical Center and a team member.
Thank you so much for joining us. Dr. Moriatis.
Hey everyone, Chris Morades. I am also a hospitalist, doing hospitalist stuff today at Dell Medical Center, and I'm at Dell Med School and part of the Shout team.
Thank you so much. Dr. Christian.
Hey everyone, I'm Nick Christian. I'm a current fellow at the VA in Connecticut, but former B team member and a consultant for Shout Texas.
Thank you for joining us today. Alana.
Hi there. Good afternoon, everyone. I'm Alana Bolton. I'm Director of Shout Texas at Dell Medical School. Thanks for being here today.
Thank you all for joining us. And with that, we will get started with our didactics.
Hello.
Ready?
Okay. My share screen working? Yes. All right. Here we are. So thank you so much for having me to do this. And then we have a really interesting case coming up. This is very short and sweet. I just tried to pull together stuff straight from my brain of how to support people taking care, providers taking care of patients in medical hospitals with co-occurring substance use disorders. Probably need to amp it up based on all the questions you guys might have. No disclosures. So basically, we're going to talk about just like the basic options for co-managing opioid and alcohol / benzodiazepine withdrawal as a really low-hanging fruit. We'll talk about amphetamine withdrawal. We're also going to talk a little bit about available medication treatment for alcohol use disorder and opioid use disorder. So the first and most important pearl is don't panic. And I say it over and over again, but don't panic. So thinking about like probably the lowest hanging fruit and the thing that most people worry about is this co-occurring. People are tolerant to both benzodiazepine or alcohol, so GABAergic tolerance plus opioid tolerance. And what the heck do you do? Here they are in the hospital. In the good old days, it was the good old days of heroin, it was really easy to get people over to buprenorphine and then focus on the GABAergic withdrawal. And that is no longer the case. When everyone is tolerant to fentanyl, unfortunately, the time frames of when fentanyl withdrawal starts to kick in is a little bit past when the GABAergic withdrawal starts to peak. It's sort of all overlapping. And so, sorry, just realize it's going to be hard to tell what symptoms the patient has. If they're coming from opioid withdrawal or benzo withdrawal, it's probably both. So just treat both. So generally my recommendation is do what you can to do it in sort of a steady state fashion as much as you can. Manage GABAergic withdrawal. I recommend scheduling benzodiazepines. Think about long acting for better coverage. Things like diazepam or Librium, as long as they're not so sick that they're needing IV. The nice thing about those agents is that they break down and even their active metabolites cover GABAergic withdrawal. So think about scheduling. You can schedule plus PRN if you need to. And then all the while, consider assuming that your patient is probably using fentanyl every day and very tolerant and has a lipophilic fentanyl still in their fat supply. So it's going to take a few days for them to really go into full-blown withdrawal. All the while opioid bridging for opioid withdrawal. Or, maybe one thing to think about is if you think they're kind of lower risk for the GABAergic withdrawal, like they're sort of dabbling in benzos or dabbling in alcohol, but they've never had a terrible alcohol or benzo withdrawal before, maybe you could use gabapentin instead of a benzo. The benefit of that, assuming their kidneys work well, is that it might be less deliriogenic for them with the cocktails of these different things. Always think about clonidine or even Precedex if they're starting to get really sick or agitated. For more severe autonomic symptoms of GABAergic withdrawal, it obviously, as many of you know, also helps a lot with opioid withdrawal. So it's only going to help you as long as their pressures can handle it. And then, like normal, transition to buprenorphine when you think it's reasonable and the patient's willing, and or if methadone is what they prefer, then transition when it's appropriate. And generally, like we are messaging with every single one of our sessions, always be patient-centered and flexible within reason. So those are sort of like my big pearls about this. There's been a lot more interest in stimulant withdrawal and trying to focus attention on this very undertreated syndrome in medical hospitals. So again, my big message is don't panic. And just realize that when someone might be using stimulants and opioids at the same time, and they do have a very significant tolerance to stimulants, it's okay to be generous with benzos in the hospital to help with stimulant withdrawal. Again, always think about what your goal is. We're trying to avert AMA discharges. We're trying to help people stay for care so that we can work with them to try to move towards sobriety and kind of do all of our things that we do to help patients try to kind of think about their situation and maybe move towards a little bit better health if we can help them to. So, temporarily, I always say, hey, this might not be something that we're prescribing when you leave, but gosh, you want a little Ativan or something to help you feel a little bit better, tends to kind of unruffle feathers, help patients work with their nurses, help them be a little bit less irritable, and just tolerate being stuck in the confines of their hospital room. And then you just manage opioid withdrawal as usual. Are you going to opioid bridge or not? What you normally do, which we've talked about in other shout echo sessions. So transition to bupe when you think it's reasonable and the patient willing versus methadone, which we're going to talk about with this case. And again, be patient-centered and flexible. I think we're missing some of my slides. That's okay. I'm going to pull up my other slides. Let me make sure it's not at the end. Yeah, they're missing another slide. I'm so sorry about that. I think one thing to think about while I am unsharing my screen and trying to go find my other slides is that co-occurring use disorders are the norm, not the exception. So most people are using lots of substances all at the same time. And so it can feel like it's challenging. I wanted to review with you guys alcohol and the alcohol medications that are available, because you want to have those in your tool belt to potentially add to buprenorphine if somebody needs it. So let me see. I think this is the right one. Okay, yes. Let me share this screen. Okay. Sorry. Okay, here we go. I have too many windows open is what happens to me. Okay, this is it. Can you guys see that better?
Yes.
Okay, sorry about that. Let me advance to this to the right side. I'm sorry, we had a little bit of, it's pretty much the same thing. There. Okay, here are the FDA approved medications for alcohol use disorder, right? So number one, naltrexone, right? If somebody is using methadone or buprenorphine, naltrexone is not their medication. You guys know it's an opioid receptor blocker. There may be some patients who really don't want buprenorphine or methadone. They're also drinking alcohol if they're also using stimulants, and they're willing to take something. Naltrexone may help with all of the above to some extent at least. They're going to lose opioid tolerance. They'll be at risk for opioid overdose for sure. You're always sending Narcan and all those sorts of things, but in a patient-centered way, if someone is absolutely against buprenorphine or methadone to help with their opioid use disorder, this is indicated for alcohol use disorder. This is indicated for opioid use disorder. And there's some evidence that it may help with stimulant use disorder and other cravings as well. We use it in binge eating disorder. We use it in lots of different things. So something to know about. You're wanting to always ensure opioid abstinence. The general recommendation is 7 to 10 days. I've seen people tolerate much sooner than that, as far as just sort of depending on what opioid they were using before. You want to, these are recommendations straight from ASAM. It's good to just know what their liver's doing and then checking it later if they're staying on naltrexone, but I tend to offer a lot of reassurance. I work in the medical hospital. I work very closely with the GI docs. And as our colleague and friend, Dr. Weems, like to say, if someone has a sliver of liver left, you can use naltrexone. So if they have some functional liver capacity, their liver will likely handle it, especially if they're poisoning their liver with alcohol and it's, they're sort of near getting to like end stage cirrhosis, but they're not there yet. It's appropriate to try with a lot of support and monitoring that it's actually helpful and worth it. There is long-acting naltrexone injectable. And then not to forget, acamprosate and disulfiram. I admittedly don't use them often. I've started to use acamprosate a lot more. Acamprosate's big pearl is that you've got to have pretty okay kidney function. So if you're talking about like higher stages CKD, this is not an appropriate medication for a patient, but it's thought to stabilize the sort of GABA glutamate dysfunction that people have who are drinking or using benzodiazepines in particular. When they're off of those and kind of help them tolerate being sober again, abstinent again. And then there's disulfiram, which is antabuse, which is, a sort of daily communion of, I'm going to get sick if I drink on top of this and I'm not drinking today. It works for some patients, not all. It's certainly, it has a little bit less evidence and it depends on the patient. But again, it's good to have it in your tool belt because there are some patients who really want to take it and they really like it when they do take it. It can be overcome, the effect of it. So you should know people can certainly drink on top of it and drink through the sickness. And actually, if they do a pretty big dose of alcohol, they get through it pretty quickly. But it is kind of in the tool belt and something to know about. So that's the main pieces of information I wanted to talk with you all about. You can use methadone and buprenorphine with the acamprosate if a patient wants to try that. And we had a question before we started to sort of address the idea of someone with both a significant opioid use disorder and alcohol use disorder concern who's in methadone clinic and under methadone care. And their methadone provider had heard that they were struggling with alcohol and had specifically increased their methadone dosing to try to capture, not necessarily alcohol withdrawal is what I heard was the reason. Methadone doesn't treat alcohol withdrawal, but it certainly could give a person relief and sort of tamping down, I could theoretically think of sort of a little bit more sedation, a little bit more calm, where it might cool off whatever the person is getting from using alcohol on top of methadone to just take their methadone. And so that was something that they wanted me to kind of address, is something to be aware of. I think that sounds like a totally reasonable plan for that patient. So to recap, don't panic. Co-occurring substance use are the typical, not the exception. Treat what you can, be patient-centered and flexible. When you're having multiple withdrawal syndromes, just do your best to treat all at the same time, realizing it's really hard to tell what's causing what. And I think if you're talking to your patients, communicating with them, being flexible and offering things that seem reasonable, like a benzo, even if they have nothing to do with benzo withdrawal or anything like that, just, try to help them stay in the hospital with whatever tools you might have at your disposal. Obviously, treat alcohol use disorder too. Don't forget the Narcan. And I didn't have a slide on it because since we're kind of state and regional wide, everyone has different resources. But obviously, you're always wanting to provide peer support resources in your area if you've got them. AA, NA, Smart Recovery, kind of more is more, tailoring it to whatever the patient might be interested in, because that's going to be the best evidence mixture of treatment and attention to what they're dealing with. And that is it on my short and sweet, so we can get to our good case. Thank you guys so much. Does anybody have any quick questions about what we talked about? All right, then. I guess not.
Thank you, Blair.
Actually, I do, Blair.
Yeah.
I have not been waiting 7 to 10 days for naltrexone, and you mentioned you don't either, but like, how short is possible? I mean, because I've got these patients in the hospital, right, and they're getting like PRN, oxycodone, and then I talk to them about like, we're going to stop that before discharge. We're going to get you started on naltrexone at discharge. I guess I haven't been telling them to wait, honestly. I don't know. Yeah. What's the best practice there?
I mean, I welcome anyone else's input. Like, I'd probably tell them a few days, like, just to be sure, especially because they're discharging and like, if they precipitated withdrawal. But I mean, realistically, we start Suboxone hours after someone takes their last Dilaudid. Like, it's an opioid. So, you're not dropping them to nothing and blocking the receptor and displacing everything. But I think not to go against the official recommendations of the American Society of Addiction Medicine, but I think you can get away with a lot sooner. Yeah. I also counsel people, it's not a magic pill. It's just a tool. They're still going to be at risk walking out the door to using again, like an hour later or a day later or 2 days later. So I also think it's not like risky to wait a little while. It really just depends. I think it's really just about making an informed decision, letting the patient really be educated about what they could feel or not. I've seen some people say, oh, your first dose, if it's sooner than, 5 to 7 days, try a half tab of the 50, see what happens. But I don't think there's a right way. There's a question about, I have a patient who's pregnant, 39 weeks, planning to move to San Antonio day after tomorrow. She's taking Bupe 16 BID. Oh, sorry, it's just about San Antonio resources. We'll try to figure that one out while we're moving on to the case. Trying to find somebody in San Antonio to prescribe the Bupe. I hope they can find something, since there's no X waiver and everyone should be able to prescribe the Bupe. All right, let's move on to the case.
Thank you so much, Dr. Walker. Before the case, we will do some announcements from the BWell program. Maria, if you could please share the announcements. Thank you so much. The Center for Substance Use Training and Telementoring provides high-quality education in best practices for responding to substance use. CSTAT can help enhance professional knowledge and self-efficacy to treat, screen, and make referrals for people with substance use disorders. To learn more, please visit us at cstat.utisca.edu. Next slide. Please remember to text today before midnight to receive your CME code. You can text attend 1009 4968 to 844-502-1338 to receive your CME. Maria will be sharing this information in the chat as well. Next slide. A quick reminder, we will be starting our brand new Echo, the Behavioral Health Echo, on Friday, September 29th from 12 to 1 p.m. Please do join us. You can register using the link in the chat. We will be chatting out all these links in a bit. And this Echo will be held on the last Fridays of every month. So do join us. Next slide. Another new Echo starting next month. We will be starting the Recovery Science Echo for those interested in the recovery sciences. This will be on every third Wednesday of the month from 12 to 1 p.m., starting on Wednesday, October 18th. Next slide. And finally, our next Shout Echo will be on Thursday, October 19th. We have an interesting speaker lined up, so please do join us. Thank you. And with that, we will move on to the case. Maria, if you could please share the case, and Dr. Ramesh, you can take it away.
Thanks, everyone. So I'm presenting today's case today. This was a patient that I took care of a couple months ago for about a week in the hospital. The history of present illness, he's a 50-year-old male with chronic IV fentanyl use who presented at the end of July with several cutaneous abscesses on his torso. And the abscesses were prior injection sites. He used IV fentanyl. So he came in with these large abscesses, and the last time he used fentanyl was immediately prior to emergency department arrival, just the day before. He had had a couple of admissions like this before for like a right lower extremity abscess back in June, and he was treated for that. And at that time, our B team was consulted for opioid withdrawal management. The team spoke with him, and he was really quite hesitant to start Suboxone. So his withdrawal symptoms were managed with short-acting opioids as well as some adjunctive medications. And he was somewhat well controlled on IV dilaudid and oxycodone two-step 10 milligram doses. But unfortunately, during that admission, he left against medical advice before they could further discuss Suboxone initiation. And since it had been less than 72 hours since he had admitted, they weren't able to start Suboxone at the time. And at that time, he did say that his pain regimen was insufficient at that time. So his past medical history, he has opiate use disorder, as well as multiple admissions for skin abscesses. He doesn't take any medications at home. When he was admitted to the hospital, he was started on broad antibiotics with vancomycin and zosyn, and then some adjunctive medications for opioid withdrawal, including baclofen, clonidine, bentyl, loperamide, lorazepam, trazodone. And then he was started on oxycodone, which was kind of titrated up slowly over the course of the first week that he was here, such that by the time that I joined the team taking care of him, he was taking oxycodone 20 milligrams Q4 hours, and then 10 milligrams as the second step Q4 hours, as well as IV dilaudid 2 milligrams Q4 hours for breakthrough pain. And he seemed to be okay controlled on that. In terms of his social history, he lives in government housing with a service dog and a wife who is also disabled and in a wheelchair. And he does not have very reliable transportation, from what I can understand. Like I said, the psychiatry and B team had evaluated him on his prior admission, and he was treated just for opioid withdrawal with adjunctive medications. He did not have any psychiatric comorbid conditions diagnosed at that time. The patient did tell me and multiple members of my team that he had been on Suboxone before, but he had had a precipitated withdrawal. Whereas last time in June, he was somewhat, considering Suboxone. This time he was really adamant that he did not want to try Suboxone. And even though when we joined his team, it had been more than a week since he had been in the hospital. So we explained to him that he would be in pretty low risk of entering precipitated withdrawal if we started Suboxone, but he was not really willing to try it at that time. So at this time, he was started on antibiotics, and we did discuss methadone with him, and he was interested in starting methadone. In terms of his actual infection, he was going in for multiple surgeries with the surgery team, with debridements, wound vac placements, and antibiotic switches. So he was going into the OR every 2 or 3 days for procedures like this. And the week that I was on, the plans for the 3 wounds that he had were for a split thickness skin graft for his left upper chest wound. The right shoulder wound was going to probably be closed during the week, and his right leg wound would need an ongoing wound vac. And so because of the complexity of these wounds, the surgery team and the wound care team tentatively told us that he would need short-term skilled nursing placement, most likely after he was done with his immediate surgeries. So for the first week, his withdrawal and pain were controlled with the 20 milligrams of oxy Q4 and 2 milligrams IV Q4 dilaudid with additional 10 milligram oxy for 2-step. And he said that his pain was not super well controlled on this. And so we decided to start methadone. I actually consulted Dr. Walker for help with methadone because I had not started methadone before in a patient like this. And the plan was to start methadone at 20 milligrams twice a day and titrate up to 20 milligrams 3 times a day for his discharge dose. And so the way we did it was 20 milligrams twice a day on day 1, 20 milligrams twice a day on day 2. And that's when we also decreased his oxycodone and dilaudid by 50%. And then we titrated up to 20, 10, 20 on day 3. Kept it the same on day 4, and then 20 TID on day 5. And we further decreased the oxycodone and dilaudid by 50% that day. So we checked EKGs every other day since his QTC was a little bit borderline. And we kept in touch with the methadone clinic via text. The methadone clinic provider said that there was a spot open at the clinic that was closest to the patient's house. And we did communicate the discharge dosing of 20 TID to the provider, saying that we were going to switch it to 60 milligrams once a day by the time the patient was discharged. Our hospital substance use navigator was speaking with the patient daily, sent the methadone clinic referral, and provided the patient with the phone number and the addresses, and was checking in with him every day. Couple of things I wanted to point out. The patient did want to leave against medical advice multiple times for a few reasons. One, he was very worried about his wife at home and his dog. He was frustrated about the ongoing surgeries that he was having and the lack of communication about them and the unclear plan for wound closure. Essentially because every other day he would go for surgery and they would have a tentative plan to do something, and then based on the appearance of the wounds, they would say, well, this needs a couple more days to heal, or we need a couple more surgeries for this. And so this was really frustrating to him because there seemed to be no end date in mind. And then he was also still kind of dissatisfied with his pain regimen. So initially we tried to manage some of these concerns. We actually called a lift for his wife at the beginning of the week so she could come and spend some time in the hospital with him, which was helpful for him. But she did have to leave in the middle of the week. We tried to provide updates as frequently as possible once checking with the surgeons in the morning. But this was sometimes fragmented since the surgery plan would change often. When we did start the methadone, it was helping him, but he was continuing to endorse 8 out of 10 pain on most days. But some days when he was endorsing this pain, he would be a little bit somnolent. And this is when we would kind of taper the short-acting agonists a little bit, because we were worried that that was contributing a little bit to the somnolence as the methadone reached steady state. Unfortunately, the patient did end up leaving overnight on August 11th, which was the last day that I was on service, because he just really missed his wife and his dog. So the surgery team came by, removed his wound vacs at bedside, and he was discharged without any opioids. We did send Narcan and antibiotics to the pharmacy for him to pick up the next morning. And then he left. He did re-present to the hospital, fortunately, a few days later, for ongoing treatment of his wounds. He underwent a few more procedures with surgery, eventually undergoing skin grafting on his chest wound and closure of the other 2 wounds. During this hospitalization, he was continued on the methadone dose from the prior admission, which is 20 TID, as well as the oxycodone and Dilaudid as needed for acute pain needs. He was discharged at the end of August with a taxi voucher to the methadone clinic. I do not know if he actually made the methadone clinic, since I don't have the records for that, but I have not seen any notes in the chart that he came back to the hospital for anything. A couple little logistical issues about the methadone clinic, which we were kind of worried about, was that the fact that this patient would need to go to a skilled nursing facility after the hospitalization. And the policy of the methadone clinic is that the patient needs to come to the clinic for a face-to-face appointment before they can dispense methadone for them. If he were discharged home, then he could get a taxi to the methadone clinic straight, and this could happen. But if he were going to a skilled nursing facility, usually our hospital doesn't allow the patient to go elsewhere, like home or a clinic appointment, before they go to the facility that they need to go to. So I think during the times of COVID, the methadone clinic was allowing for virtual face-to-face visits via an iPad, but they were a little bit hesitant to do that now, because they had had some experiences with patients leaving AMA from the skilled nursing facility after the methadone had already been sent there. So they were a little bit hesitant about arranging a virtual appointment for this patient. So this was something that was kind of worrying to us, because if this patient went to the skilled nursing facility, he would go there and he would not have any methadone there. So we were sort of in talks with the methadone clinic provider about this, and they were going to check with the supervisor to see if something can be arranged for this patient. And, you know, this patient unfortunately discharged AMA before this could all be figured out. And then it ended up working out in the end. But this was something that came up, and I just wanted to point that out. So I think my questions or discussion topics for the group here that I would love your input on is, this is my first time titrating methadone in the hospital for a patient who has opioid use disorder, as well as acute pain due to his infections. So what are your experiences titrating methadone and the management of your full opioid agonists when the patient is, you know, going to surgery every other day and has ongoing acute conditions? And then any other issues that you have had establishing patients at a methadone clinic, which we know is can be really logistically difficult here in this city, and any tips or tricks that you could provide for that, especially if the patient has complicating factors like needing to go to rehab or skilled nursing. And then any strategies on reducing the risk of self-discharge in a patient like this with a few family issues at home, and then coordinating communication with surgery teams or other consultant teams to make sure that the patient is feeling empowered and involved with their own care. So I'll kind of stop there and open it up to discussion and see if anyone has any input.
Thank you so much, Dr. Ramesh, for this amazing case. And I will open up the floor for any questions or comments from our learning community here.
Thanks, Jan. This is Blair. That was fantastic case. And I guess let's just put to the community the first question for methadone titration and like acute pain management at the same time. What have people's experiences been like? Anyone have any tips or tricks? Bueller. All right, I'll jump in. I do think, so I guess everyone should be aware, and I think the last time I checked, I wish we had Dr. Weems on, who's like, works closely in outpatient or a methadone clinic doctor here. The general methadone titration in the clinics on the first day for someone who's opioid tolerant is 30 milligrams plus a later 10, like per the regulation. And so that's where this sort of 40 in the first day, but you split it up to like cover pain a little bit better came from. You probably can get away with a little bit faster getting up to 50 or 60 when they're in the hospital and going to stick around when you know they're very tolerant to opioids. The acute pain management, I mean, I think the main thing that I would pass on is you think of the methadone as trying to get it up. It takes forever to get up to a dose that captures their full opioid tolerance. It has a stacking effect. So you'll see palliative docs, like they'll put methadone on in someone who's naive and they do not increase the dose for another at least 5 days. It's because you can increase it too high and then it stacks and stacks and you don't realize, and then whoops, you've overdosed them. Again, when you know that someone is very tolerant, we can go a little bit faster. They're in the medical hospital. They're somewhere where the nurses are actually really seeing them very often. So they'll start to get sleepy before they stop breathing. So we can go a little more aggressively, but that's where the kind of fairly cautious titration. I have seen more significant sedation start to happen, doses over 80. Maybe 90, where people it really does start to stack up, and you need to then slow down and go a lot slower. And as you're kind of creeping it up in the hospital, like every 3 days going up, maybe 10 milligrams past 90 rather than quite so fast. But I think you got to get them up to at least 40, get them up to 60 really quickly to like capture the withdrawal piece. And then think of methadone as that's just their baseline of like a person who's completely opioid naive. The pain, acute pain on top of methadone should be just like anybody else, but realize that maybe they have some tolerance and they may need a little bit more. And so I think you have to kind of tailor it to the patient. Jan, I think y'all did a masterful job with this patient. I think you did the best you could. He was getting sedated and needed to have those pain medications tapered back a little bit. I mean, I think you did really great work with him and were very patient-centered and very flexible in what you're trying to do to try to help him stay in the hospital. Does anyone else have any thoughts about the first question, like the methadone titration, acute pain management piece?
Yeah, I can weigh in. I know that for my clinical practice and for my training at my institution, we usually start patients on methadone, as you said, Blair, 30 milligrams, and then give another 10 milligrams at night. And we escalate by 10 milligrams every day up until they get to 60 milligrams. So 30 and 10 on day 1, 40 and 10 day 2, 50 and 10 day 3, and then 60. And then if you look at a lot of the studies, the doses over 60 milligrams, that's where the risk of overdose really goes up. And so we usually hold at 60 milligrams for a couple of days and then continue to increase from there. Now, there have been, at ASAM, there was a talk on rapid methadone protocols that are being tested. OHSU has one that's pretty wild. They start at 60 milligrams and go up by 10. And this is for patients who are opioid dependent and tolerant, using high doses of fentanyl. And so you're able to get away, I think, with a lot more than what you'd expect. When you're treating pain on top of the methadone, I don't even consider methadone as necessarily treating pain in this acute setting, because you're mainly just trying to correct people's opioid deficit. And so you use the methadone to try to overcome their opioid deficit while using short-acting medications for pain on top of it. Once someone is at a higher dose, then you might start to see some effects. And once they're through the acute pain period, you might see some effects of methadone on pain. And Blair, I'm curious to hear your perspective. Do you often split dose methadone for pain? I know that sometimes you get better analgesic effect if you dose it twice daily or 3 times a day. And that's another thing that you can consider down the road for these patients as their acute pain kind of starts to subside.
Yeah. So yeah, I definitely do, which is where that sort of came from. And actually, I might even do 20 BID the first day, and then 20, 10, 20 the next day, and then 20, 20, 20 the third day, and like hang there. And then I give them high dose available opioids, and the sedation is probably more likely coming from the acute opioid at first while the methadone's still kicking in. But yeah, I think the other thing, and this is a unfortunate stigmatized regulation of methadone, is that the methadone clinics are not allowed to manage pain. Hard stop. So they can't, that's where that weird going to the sniff thing is a problem. They can't, I've had some of the methadone doctors be able to wiggle while they're in the sniff. They're not even there giving it. Like, they deliver the methadone, so they're okay with like a little bit of a split dose while they're in the skilled nursing facility. But for the most part, they can't dose methadone more than once a day. When people build a takeaway and they've got chronic pain already, like build the, allowance to be able to take away their methadone, everybody splits their methadone dose up if they have chronic pain, because it does work better that way. You definitely have a wearing off effect into the evening. So it's just this weird regulation that sort of stigmatizes and makes it harder for us providers to appropriately manage the whole patient rather than just the opioid use disorder. And so we just need to keep on like advocating and working from within to kind of manage that regulation. And I think they're taking a hard look at methadone now that they've released the X waiver and, trying to kind of destigmatize the way the regulations are set is what I'm hearing from my methadone clinic colleagues. The other thing is this virtual visit thing. And it's just a frustrating, it's still I think it's still under review, and they haven't officially like decided about what's going to happen in outpatient clinics versus the methadone clinics. I have had patients that they've done virtual visits even recently. So I think it's something that we'll try to go from within. And Jan, my question for you was, who was that? Was that, I know this isn't totally relevant to folks outside of Austin, but was that East 2nd Street Clinic or CMS?
It was CMS.
CMS. So CMS has been the one that's been so flexible. So it's interesting that they're kind of having a change of heart, or maybe getting a little bit nervous as we're getting away from COVID and like the emergency use authorizations and things like that. So, it's going to end up being another barrier, unfortunately, to, the way it used to be, which was, sorry, you want methadone, but you're going to need a sniff. There's no way in heck that we can get you like to a sniff. We can't give you methadone, whatever. So, I don't know. So I think that's kind of a bit of a frustrating piece. But yeah, I mean, those are the main things I know about the methadone titration. Do other people have any ideas about methadone clinics? That we're sort of already talking about it. My only thought is that we need to try to formalize that in our area. If you guys don't have good connections with the methadone clinics in your area, it's a good thing to have connections, at least in Austin. 5 years ago, when, like sort of around the time, sorry, I have to dance around my room to get the lights back on. 5 years ago, when we first started the B team stuff in Austin, it was like impossible to get people into a methadone clinic. It was only pregnant women. We had a few cases where someone would have to be in the hospital for like 6 weeks of IV antibiotics, that we got them a methadone stable, and we called like the first week and checked in multiple times a week to like get them a spot. But it really has made a big difference in our area as the methadone clinics have been more available, as county resources have been funding spots at the, at CMS, which is like not like an official county run methadone clinic and things like that. And so it's just nice to have those connections. Like we have so I would encourage you to do that wherever you are. to just know what's out there and to be able to confer with the methadone doctors, because they'll be able to tell you exactly what you need to do in managing the methadone, and also in what they can do to try to meet the needs of your patients within the regulations that are kind of handcuffing them a little bit. So they didn't used to, for instance, like deliver methadone to the SNFs, and now they totally do in our area. So it's actually sometimes, you know, it's become almost as available as buprenorphine, really. The last question was just thoughts from the group.
Hey, Blair, I just want to
Yeah.
make sure you see. So Zach asked a question in the chat that I think is relevant still. Patients with acute pain, e.g. early postoperative period, do they ever get turned away when they go to their OTP intake? And then I also see that Lindsay has her hand up as well, maybe before we go on. But
Oh, thanks. So like turned away, like because they're on acute pain meds, I wouldn't expect it. And I wish that Dr. Weems were here, because he's like taking my handcuffs off about giving this patient, say he was on methadone and discharging and has acute pain needs. Is it appropriate to send them with a short-term, short-acting opioid on top? I mean, he's going to use fentanyl to treat his pain if we don't help him treat it appropriately. You know, we wouldn't torture our non-opioid tolerant patients with untreated pain when they had abscesses all over their body if they were discharging. So why do we torture our opioid use disorder patients who are at higher risk for going to some other alternative that might kill them? I think the bottom line is, I think that the outpatient, and I think you're saying OTP, you mean like the narcotics treatment program, like an NTP, a methadone. I don't think they turn them away. I think they would talk to them about it, but I'm not a methadone clinic doc. I mean, I think they'd get them on methadone and, you know, consider that they need to be on methadone. They may say come back, but I can't answer that for sure. Does anybody else know the answer to that question?
I do. So I have seen them
On methadone, I don't think would turn them away, but others might.
I've seen them be turned away or get kicked out of a program for coming up with pain medication, which is devastating, you know, because they're in pain and they're like, even if it's, I've seen them do it definitely as a peer. Which that was going to be another thing that I said that I was going to say was that you can, peers, usually peer provider, peer service specialists, or whatever you want to call us. We usually have really like good relationships with the with places like CMS and other methadone providers. We have often had peers that go into those types of providers, and that's a great place to start building that relationship, because, you know, we're there and we work with them as well. And then we can also work with the person who's needing kind of some of that advocacy experience. My other thing I was going to ask about is, what, instead of, if opioids are not an option, what about using something like ketamine for pain?
Thank you so much. That is so relevant. And again, sort of like what I was talking about. I mean, the thing is, if we have good, easy access to the methadone clinic doctors from the hospital, then you can say, hey, this guy just broke his femur. We're keeping him on his methadone, you know, but he was in a terrible car crash and we're absolutely giving him this on top. He's going to be positive for opioids when he comes back. We gave them to him in the hospital. What do you guys want to do? What's your comfort level with the treatment plan when he discharges, because he needs to go, you know, that sort of thing. And so I think that's where I think making those connections in your community so that we can get these patients the proper and appropriate care and advocate for them so they don't get kicked out of their methadone clinic if they get in a car crash and break 15 bones and need some help. What other questions are there? Before I jump on to the last question that Jan brought up.
I wanted to point out that even though there were some like frustrations with this case, I was like really impressed with the fact that I was able to text the methadone provider on the phone all week and keep them updated about the dosage that the patient was on and the surgery plan and when we thought there would be a discharge. And I brought up the SNF issue before he was discharged so that she could begin working on it on her end. So I was really impressed with that kind of multidisciplinary communication, and our lovely substance use navigator was also keeping in touch with the patient, keeping him updated, sending the referrals. So I think it was a good example of like communication from different parts and different disciplines. And it was very helpful and made me feel more comfortable in giving the methadone. In terms of Lindsay's question with ketamine, I don't have any experience with dosing ketamine in the hospital for patients with OUD. Would love to hear about people's experiences with that. I'm always open to new things that work for patients.
I'm looking for the text about it. I mean, there's certainly rising evidence, especially ketamine for opioid withdrawal. I'm waiting for a case of precipitated withdrawal who maybe that works better than Ativan and a lot more buprenorphine. But I also don't have a ton of experience, but I'm ready to experience it. It's a mounting thing. Dr. Christian, you're in addiction medicine training right now. What's the scuttlebutt on your end as far as using ketamine? You guys have anything yet? I put him on the spot, but maybe he's not.
Yeah.
Yeah, I actually just, can you guys hear me okay?
Yeah.
So yeah, I just had a case report published on treating a patient with precipitated opioid withdrawal with ketamine in the hospital. I'm happy to share that, or I think I might be presenting it at one of the future echo sessions. But ketamine in the setting of precipitated withdrawal, it's been incredibly effective for at least 2 patients that I've seen in the hospital setting. At my institution, the anesthesiologists are very savvy with ketamine, and so that's usually who gets consulted, like a pain management service, and it's incredibly effective as well. I think the dosing is usually like 0.1 mgs per kg, mgs or micrograms per kg, up to 0.5. You might want to check that, but anything higher than 0.5 or up until like 1 is where you start to see more of the dissociative effects. And so those lower doses are really effective for analgesia, really effective for precipitated withdrawal, anxiety, and we're using it more and more in the post-operative setting when we're trying to spare opioids for patients.
Yeah, and you know, for the right patient. So in my hospital setting, or at least the hospital setting where I normally work, with our burn unit as well. So we'll have people on kind of low dose ketamine drips too that can work very well, again, for like acute but like ongoing terrible acute pain. And I think we've had a couple of patients that were on a ketamine drip on top of their methadone. That was like their methadone clinic methadone after a bad burn. So I think we'll see it more and more. I think we'll also see it more and more kind of oral forms like ketamine troches. I think there's pluses and minuses, and ketamine is also very habit forming as well. So it's something to always watch out for, but it can be really effective. So cool. The last question.
Dr. Walker, we have a question from Zachary here.
Oh, okay. Yeah, go for it.
Hey, Blair. Sorry, it took me like 5 minutes.
No, not at all. I can't
raise my hand.
Show me everyone's hands.
Part of the reason I asked that question about methadone clinics and patients with acute pain is that we recently had that come up, and my partner Ishao Chen had reached out to one of the local clinics, and he was actually told that it's against the law for them to be on a prescribed opioid and get methadone through the clinic.
And I mean, I honestly don't know officially the law for the methadone clinics. There may be a law for them. I mean, to go back, and Dr. Christian's in his addiction medicine training now. I took the addiction medicine boards like grandfathered in a few years ago. And in my studying, you know, the whole point of the Data 2000 update and legislative update that led to the buprenorphine X waiver was because there is a law on the books federally that says it is illegal for physicians to knowingly prescribe an opioid to an opioid addict, or like a heroin addict or whatever. That's from like 1910 or something, but it's there and it sits there. And so it's not evidence-based anymore. And so, you know, you'll hear people on the forefront of opioid use disorder treatment, treating the whole patient, like Dr. Weems, like me. I'm learning from him, but you know, that we need to be treating the patient, meeting them where they are. And so it's kosher, and it is presented even in national lectures, that it is kosher to give prescriptions to patients with opioid use disorder to treat their acute pain within reason, but it also may still have that law on the books that, you know, might be this gray area of, could you be risking something or other? I think that if you're not running a full-blown pill mill, you're going to be fine. But, you know, I think it's always something that there's always this tension. And in my culture of my hospital system, the surgeons are really nervous about prescribing opioids in general, just because of the opioid epidemic. They're probably stingier than anyone else because of all of that. The pendulum has swung the opposite direction. So I think it's still a kind of a tension area in our practice, this whole of, what do you do in the middle when they're leaving the medical hospital, but they're still having a lot of acute pain? One of the answers is always hit them with multimodal regimens of everything else that you can give them to cool things off. So again, we may see more ketamine over time, when we all be getting a lot more comfortable with things like that if we feel like the cuffs are still on with opioid prescriptions. I want to be mindful of the time. It's 12:57. We talked a little bit about like methadone titration, methadone clinic stuff. Reducing AMA tips and strategies. Does anyone have any thoughts really quickly? My thought is, Jan, y'all did a great job. You lifted the wife to come visit him. Like, that's awesome. I feel like you bent over backwards to try to help him. I think the main thing is just being flexible and patient-centered, which you absolutely were. I don't know if anyone has any other thoughts on strategies to avert people self-discharging from the hospital that maybe you didn't see with this case. Any thoughts?
We have a question in the chat about microdosing psilocybin. I hope I'm pronouncing it right.
I'm not sure there's any evidence specifically for microdosing psilocybin for acute pain. I don't know if anyone else has anything to put input there. It's still really being studied. I mean, I'm in the psych realm. We have, you know, our psychedelics research kind of institute with Dell Medical School that's, you know, doing a lot of studies now. Most of the studies are, you know, associated with like microdosing psilocybin plus therapy for whatever specific thing that you're trying to do. But other people like chime in if you have an idea. I think either way, unfortunately, it's not really available. Like, we're not giving psilocybin in the medical hospitals these days. It's just not, it's not on formulary, like it or not. So maybe someday. And I think that this is the wave of the future. And I think 30 years from now, we'll look back and say, woo, look at all the cool stuff that happened while we were on the, you know, on the front lines of all of this. I'm going to recap really quickly. We talked about this really great case with Dr. Ramesh, and I think you guys did a masterful job of taking care of him. Learned a little bit about methadone titrations and splitting dosing for kind of covering pain while in the hospital, but also the barriers of getting to methadone clinics and being able to be treated in a sniff in between the methadone clinics and not being able to treat acute pain in methadone clinics. We learned from Dr. Christian in particular, which when you're titrating the methadone, about doses over 60 being higher risk for opioid overdose, kind of holding there to watch for that stacking effect. Talked a little bit about the methadone barriers and methadone clinics. If you don't have connections in your system, but you want to be able to get your patients into methadone clinics, make those connections. And then we talked a little bit about reducing AMA discharge tips and strategies a little bit, just like, I think just being flexible and patient-centered and doing what you can, thinking out of the box, like Dr. Ramesh and her team did with this case. I think we're done and at time. If anyone has any last thoughts, Shreya, you're in charge.
Yes, thank you so much. This has been an amazing discussion, and I'm sure we could have stayed longer to discuss, but thank you all for joining today. As a reminder, please text the code, the CME code by midnight tonight to receive your CMEs for this session. Please do join us at on Thursday, October 19th for the next session and Shout. and have a wonderful rest of your day. Thank you.